So in DKA people, what happens is they don't have basal insulin, right? Or let me just scratch this 1 second. DKA type 1 diabetes don't have insulin, right? So what happens is the body is going into glucose is going up in the blood. If they eat, the glucose stay in the blood, and then if they're not eating, well, they don't have any cells here sitting here, right? And if they don't have glucose, their body thinks that they are actually in starving phase, and they're just gonna keep on glucose, and then here it is. This is glycogen is burned down already. Their body thinks they are in a starving state. So basically, their body is always thinking they are in starving state because of the no insulin. Starving state because no insulin, right? So they're always kind of thinking in a starving state, right? So they actually break down the glycogen, so they're increasing their glucose in the plasma, but however, they cannot remove the glucose to the cells, right? Because again, you don't have insulin. And then what happens is their body thinks, oh my God, maybe I don't have a glycogen stores. Maybe there's, even though there's 100 grams of insulin or a glucose or 100, 200, the body thinks maybe there's no glucose present, right? The problem is the insulin, right? So then they go into gluconeogenesis, right? Because the glucagon is higher, right? And then now their sugars is even going into 300s, right? But they still cannot go into the cells, right? Right? So essentially, their body is always staying in starving state if they're not taking insulin, right? So then this is your gluconeogenesis is going up, and your sugar levels, which is starting at 100, it's going, instead of staying at 100, it's going to keep going up, right?
Yeah.
So now what happens over the time, if you don't take insulin, your body stays in the starving state, right? You're going to keep on doing gluconeogenesis. You're going to keep on doing sparing the proteins. At some point, even though the whatever glucose that's there, it's not going to be used up efficiently. So you're going to have maybe 500-600 glucose levels. I don't know, maybe 400 or something, right? So your sugars, the key thing is your sugars are elevated, right?
And they keep going up.
It's keep going up. And because of the insulin is entirely not present in type 1 diabetes people, especially type 1 diabetes, they have no basal insulin at all. So what happens is they're going to have ketones increase too, right? Right. So that's what happens in these people. So when they come into the hospital, what do? Well, we check their blood sugar. We take the sample blood. What do we look? We look at the chemistry panel, right? So usually what happens is usually the sodium is, let's say the sodium here is we said 135 to 145 normal, right? Now we go back, because since this is not a normal anymore, right? There's no insulin. They ate something, their body's staying in the starving state, they're hyperglycemic, their ketones going up, right? So their sodium levels are usually 135 to 145 normal. But what happens, now you're pulling in all that water that we talked about in the first video, right? So now because of this osmotic value of the sugars that is going up, right, it's going to pull the water in. And again, what it's going to do, it's going to dilute your sodium, right? If it dilutes your sodium, and then what happens to the sodium level? So when we draw the labs here, well, you have a lot of water here, right? So the liters, the volume is going up, right? Again, we said molarity is equal to mass over solutes, mass of solutes, right, over volume. And if the volume is going up, you're going to dilute your mass, right, which is the sodium. So which means what is going to happen here is your sodium is going to be I don't know, let's just hypothetically say 126 or something. Okay, so it's the 126 sodium, and the blood sugar is what? I don't know, maybe let's say 500 or something like that. But usually DKA people you will tend to have less sugar levels than HHS people, but we are hypothetically making this case. So let's just say I don't know, let's just say, make it simple, 600. Let's just make it that. Okay. So that's what's happening. So 126 is a sodium, right? And then on the top of that, these cells, since there's a lot of ketones in the present in the, because these cells will not be able to use glucose to make ATP, so they're gonna the liver has to make, other cells has to make a lot of ketones, right? So liver is doing gluconeogenesis now, and they're making a lot of ketones, right? Throwing a lot of ketones. When the ketones goes up in the blood, right? When the ketones goes up in the blood, what happens to your bicarb?
It goes down.
You're right. So bicarb is going to be like, I don't know. Usually it's normal. Bicarb is like 22 to 24, whatever, depending on like which hospital you're working at. But like usually in these people, because of the ketones, ketones are acidic in nature, right? And ketones like that. Remember organic chemistry. So ketones are acidic in nature. So what happens is it's going to drop down your bicarb, which is going to be, I don't know, let's say 14 or something. Okay, so this lab is 14, and sodium is this, right? And BU and creatinine can be like depends, right? So these labs variable depending on like what their kidney functions are or not, right? So that's what's happening. And then your potassium and these people. So now let's talk about potassium. So the things I want you guys to focus on is, okay, so first thing we talked about is hyperglycemia, right? That's the first thing. Because what do you do with the hyperglycemia? You pull ICF fluids into ECF, right? From in the cells to plasma, right? You put a lot of fluids back, right? So you dehydrated your cells, right? Essential, like another way of saying it, right? And second thing I want you to focus is because ketones going up, right? Right, ketones going up. So what is doing? So hyperglycemia is pulling the water in from intracellular fluid to extracellular, and then that is diluting your sodium. And ketones going up, that is bringing your bicarb down, right? And what is number 3? Number 3 is, so we'll talk about shift for acid base, right? So what is that? What do I mean by that, shift? So what happens is, because there's a lot of cells here, right? So there are RBCs here, like RBC here. There's other cells also, like mostly RBCs, right? In the blood, right? So there's a lot of RBC. So what happens is, when the ketones going up, right? When the ketones going up, ketones are going up, right? Your pH of your plasma should be around what? So now your pH of plasma should be like, what is a normal physiologic pH is 7.3534, same thing, right? 7.44, right? Or 7.35 to 7.45, whatever, right? So that is, why does that pH is so important? Is because, again, there's a lot of enzymes that are actually present. There's a lot of proteins that are actually present within the plasma, and that plasma is actually feeding all these cells too, right? So this pH is you need to maintain, because proteins work efficiently at this pH, right? Because now think about it. Let me just write it down here. If there is change in pH, what happens to your proteins? Proteins can denature, right? And that's why, when the patient has fevers, right? Why would we give them acetaminophen? to reduce their fever because their protein's gonna denature. We are kind of know that they're not gonna be getting well, so we give them fluids. We bring the temperature down because we want to make sure that their proteins or the enzymes that actually make them help them make ATP and all of the other stuff they're doing in the body should be working efficiently, right? So that's why the pH is really important. Because of the ketones, what happens to your pH here? So let me just draw on this page here. Let me just copy this here. Because of the pH, so because of the pH because of the ketones, what happens to your pH?
It goes down.
It goes down. pH goes down. And that is why when the pH goes down, so now let's talk about these three shifts that three things, main things in DKA people I want you to focus on is paste here. So what happens is to prevent, to reduce this changes in pH, we have shifts, right? So what happens is, so there's a lot of let's say there's a lot of acidic, acid in the blood, ketones. There's a lot of protons, right? So what happens is protons are going to shift inside the cell. So every proton you shift in the cell, you're gonna have to bring another positive charge outside, right? So what is coming out? What do you think? Potassium, right? Because of this, you're gonna shift potassium out of the cells. Let me see here. So shift due to ketones goes up, pH goes down, and in order to bring the pH back to the normal physiological range, you're gonna shift the potassium. From in ICF, intercellular, from inside the cells to outside, right? In exchange of what? It's in exchange of proton, right? That's what you're doing. So now what happens is usually potassium in our body is normally present higher in the plasma or present higher in the cells.
In the cells.
Yeah. So usually potassium is present higher in cells, right? So now what happens is, so this can actually cause what? This can actually cause something called pseudo hyperkalemia. Make sense?
Mm-hmm.
Because you're shifting the potassium from inside the cells to outside the cells in plasma. So that way you can shift some of these protons back into the cells so you can actually bring your pH in the same range so your proteins are working fine. But the thing is, it's a very temporary fix, right? You shifted it, but then you're still making ketones, right? So how much potassium you can shift outside the cells, right? So now what happens on the top of this is, so now imagine you have all this potassium that is actually accumulating in the plasma, right? So again, so there's one more thing happens is something called osmotic diuresis, right? So not only, so let me just make this smaller now. Okay, so resize this. Okay, so now what actually happening now is, let me see here, blood vessel, right? So I'm just gonna make the blood vessel even longer. So now what are you doing is you shifted all the potassium, the potassium is going, from the cells, and now you actually cause this potassium to increase in the plasma, right? So now this eventually will go where? So this, you know, will actually go into the kidneys, right? This blood, and this some of this potassium will be filtered out. Because now what happens is, now you think at the kidney level, right? So what happens at the kidney level, some of these, you know, there's a afferent arteriole going in to the kidney, right? The glomeruli, right? So you're filtering a lot of glucose in here into the this collecting duct. Proximal tubule and loop of Henle, right? And the collecting duct, and then it's going into the pelvis, and then eventually into the ureter, right? So what happens is you filter, because you have so much glucose that's present here, and it's going to, and also like potassium, it's going to pull, you know, a lot of this glucose here, and then you're going to lose a lot of this potassium, and eventually, like, you know, you're going to lose all of this. Let me see here. So you're losing a lot of this potassium out. So which means even though you have pseudo hyperkalemia here, your potassium is low overall, right? Because not osmotic diuresis actually reduces, further reduces your potassium in the body. Make sense? So it's really important. Usually patients with, like, you know, DKA, they come in, they have high sugars, very good. I mean, like, you know, that's the first thing check off. Ketones is high. Okay, you check that off too, right? And then usually you know that potassium is usually higher. But if these patients are coming in late, and if they should be technically pseudo hyperkalemic, right? They should be pseudo hyperkalemic technically. But if they're coming in, and if they stayed in the stage for a long time, some of the pseudo hyperkalemic potassium is going to be lost into the kidney, and what happens is they will eventually become hypokalemic. If these DKA people coming in with hypokalemia, which is even more serious, right? Because now they actually even lose more potassium. Right? If there was a pseudo hyperkalemia, then I was like, okay, well, they're actually in initial stages. They are definitely, like, you know, been without insulin for a while. But if they're actually coming in with hypokalemia on the top of that, that means, like, this very person has been losing osmotic pressure, diuresis has been going aggressively, which means if they have hypokalemia, which they should not, right? If they have hypokalemia, which means what? They have excessive amount of osmotic diuresis, which means what? They are excessively dehydrated. Right? Which means you need to give these guys, like, so much fluids, right? To make them euvolemic, and also replace their potassium so much, right? Before you even give them any insulin, right? It's so important. That's why, like, patients coming in, so now you go back to labs, right? So potassium here. If the potassium is, like, let's say, I don't know, like, let's say like 5.5 or something, 5.7, I'm like, okay, well, I mean, I can start insulin. I mean, whatever, you know, I can give them fluids. But if they're coming in, if this number is, like, let's say like 3.0, this person is trouble, right? Because they actually had stayed in the stage for so long that they actually lost even the potassium that shifted out. First they shifted out the potassium, then they lost the potassium to the osmotic diuresis, right? So it's really, really important to, like, pay attention to this value, right? Because if this is low, that basically indirectly telling you as a clinician that your patient is even more dehydrated than normally it should. So instead of, like, giving them, like, normal fluids that we usually give to these patients, you should give them more fluids, right? That's what it means, kind of. But anyhow, so that is the 4 things, you know, I want you to focus on in DKA people, right? So what are the 4 things we said? Hyperglycemia, right? Ketones, and then acid shift and osmotic diuresis, right? So if you understand this much in DKA, then you kind of know, like, you know, if you understand this much, then you know what are you going to do next, right? Then we will focus on the management part. So any questions so far on this one? Yeah, you feel free to ask me any questions.
Actually, now this all makes sense. Is there any cutoffs that we should be more aware of when it comes to potassium, where we actually stop giving insulin?
No, definitely. So I think that will come in the management part.
Oh, okay.
Yes. I mean, there are definitely cutoffs that we should be aware of. But, like, this potassium, you should expect, like, it could be normal or higher potassium. in these people because of the shifts that has, to maintain the pH. But if the potassium is low, I just want you to, for now, like when you're actually seeing your patient first time, right? You're like looking at their labs, right? Right now, before you start anything, you always want to review your labs first, right? So at this point in time, I just want you to think about the potassium. If it's very low, they're severely dehydrated. If it's high or normal, I'm thinking, okay, well, their body is definitely in, having a lot of ketones. There's definitely a shift, but they haven't lose a lot that much fluid.
They're in the early
Yeah,
stages.
but still they're still dehydrated, but they're not severely dehydrated, right? But once the potassium is low, which means like you have actually lost excessive amount of fluids, So
Speaking of the fluid loss, I've read somewhere that DKA patients, they're usually losing an average of like 5 to 8 liters of water.
Yeah.
And the HHS, they're losing close to like 9 to 12 liters of water.
That's a great question, because the thing is, in HHS, they tend to be even more hyperglycemic than DKA people. That is why. So we will like compare and contrast in one of the series, one of the videos that we will do. But yes, you're right. So like in people with HHS, hyperosmolar hyperglycemia, these people are usually like more hyper, like there's a lot more sugars that are present in the blood. Like instead of like 300-400, they have like maybe thousands gram, right? And these people, what happens? Well, like if there's more glucose molecules that are present, there's going to be more shift of the potassium, and then osmotic molecule, which is the glucose. If there's more molecules present, more osmotic diuresis, which means more dehydration, more fluids that are lost through the kidneys, right? Osmotic diuresis, that's what we call it. And interestingly, like in patients with like those diabetic mothers,
Gestational diabetes.
Gestational diabetes, right? It's gestational diabetes. That's why, like if they, how do they, the kids become oligohydronomias, right? In diabetes people, gestational diabetes, if it's uncontrolled, they can have oligohydronomias. Why? Because the sugars actually pull that fluid out. Right. Actually, sorry, they actually will become polyhydromias.
Okay.
Because of the high sugars, they will actually do a lot of diuresis, so they will become polyhydronomias. That's why in gestational diabetes. But anyhow, so that's what is the physiology behind this, abnormal pathophys about DKA. Okay. So now let's talk about management right here. So now you have a person. So management of DKA, right? So now, I want you to just think about this. This is a blood vessel, like plasma, venous, whatever you want to call it, right? So there's sugars like, I don't know, 600, 700, we're making these numbers up, okay? There's and then what? So there's no insulin, right? So what happens is this is their let me see here. And this is their chemistry panel. Chemistry panels are super important. That's why we repeat BMP levels in these patients every 4 hours, right? So their sodium is, let's say, 125, right? Their potassium is, let's say, for whatever reason, it's like, 5 point, I don't know what number you want to pick, like 5.6 or something, right? And potassium is that. And then your bicarb is like, let's say 12, or let's just say 14. And then BUN creatinine, let's say it's fine. It's going to be low. I mean, creatinine usually in these patients is usually like mildly elevated or severely elevated, depending on their kidney stage and also like how much dehydrated they are, right? So let's say it's 1.20. BUN is like, let's say like, I don't know, let's say it's 30 or something, right? And then glucose is like, let's say 650. Let's just make an even number. Let's say 700. Okay. So that's what their labs are. This patient is coming in. They have a hyperglycemia, and then they also has increased ketone levels too, right? So their pH is, let's say, I don't know. Let's say the pH is 7.1, right? So you already know that this patient is severely dehydrated, and they have a hyperglycemia, and their cells, the neurons, right? They already pulled, they already kind of shrinked, right? Because you pulled the water, into the plasma, right? So now, what is the management? So first thing is always in DKA, what you want to do is you want to always fluid, replete fluids, always replete ECF and water deficits. So I will say replace fluids, right? Always replete fluids. What is the next thing? Because what happens? Because the water actually came in here, you lost through the kidneys, right? Here. So what we need to do, we need to replace first thing first, right? And then what is the next thing we want to do? So let's say if the potassium is low, if the potassium, you check the serum potassium, if the serum potassium is lower than, let's say, 3.3, you want to replace it. Replete right away. Okay. Replace the potassium right away. Good. What if the serum potassium is like 3.3 to, let's say, 5.3 or something in this level, right? Kind of normalish range. Here, you only replete about 20 to 40 milliequals per 1 liter of fluids you're giving. Okay. But if the serum potassium is greater than 5.3, don't have to replace. Right away. So these are the 3 conditions I want you to remember. Okay. So first thing is if the potassium levels is low, definitely replace potassium as simultaneously replace fluids, right? But if the potassium is about in this range right here, right, what you want to do is every liter you're giving fluids, whether it's a normal saline, whether it's a LR, whatever, right, I usually usually there's no clinical studies. I'm not sure about the studies, but based on what I've read is so far is there's no clinical difference in what fluids you give. But normal saline, we'll talk about normal saline for now. So if the patient is giving 1 liter of normal saline, their potassium is 3.3 to 5.3, every single time you should give them at least 20 to 30 milliequals, okay? Every liter you should give them. Because again, because normal saline has what? Normal saline has only sodium and chloride. It doesn't have potassium. So every time you're going to give them 1 liter of normal saline, you're only giving them sodium and chloride, right? So whatever potassium there is, it's going to be, you're giving them 1 liter of fluids, right? It's going to dilute your potassium. That's why every time you give 1 liter, you should give them 20 to 40 milliequals, right? It's really important. And what is number third? Number third is if the initial potassium is 5.3, then you don't have to replete right away. But you have to monitor every single time. We'll get in details like when do you replace it, okay? And number 3, what is number 3? Number 3 is this is the most important. If any time a patient's coming in, do not start insulin until these 2 things are conditionals are satisfied. So important. Okay, so first replace the fluids and then serum potassium replacements depending on what their levels are. What is number 3? Number 3 is correction of. So where the problem started from? Where did the problem begin?
No insulin.
No insulin, and then what happens to sugars, right? Sugars are elevating. So now correction of hyperglycemia. And how are you going to correct the hyperglycemia? Because their body is thinking they are always in a fasting state, right? They just keep on making, they keep on doing gluconeogenesis, but the thing is, even though they cannot remove any, high amount of glucose, and if they're eating on the top of that, I mean, they're just going into like severe hyperglycemia, right? And they're making ketones, so we need to correct. We need to start telling their cells somehow that, hey, there is a glucose, please start using it, so we need to give insulin, right? So how do you correct the hyperglycemia? You have to start giving insulin, and we'll talk about how much insulin we give. So this we'll get into like each and every management like in detail, but so that is the most important thing. Okay, so correction. So what if the patient actually came in, right? If the pH is like less, if the pH is 7.1 in this guy, right? We said the pH is like 7.1, so that's fine. You don't need to correct their potassium. Okay, don't need to correct their potassium. What if potassium was less than 6.9? Like I said, some of the enzymes won't work, because they will denature, and that's why it's really important, because potassium was less than 6.9. It is most of these enzymes are not going to work. Right? So there's an immediate correction needed. So how do you correct? Well, you give them what? What is their pH is? Their pH is low. Their bicarb is low. What are you going to give them?
Bicarb.
Give them bicarb. And how much you give them bicarb? Well, you can give them like 150 milliequals, which is another way of saying is, you can give, so this is like 1 amp of bicarb has 50 milliequals, right?
Mm-hmm.
So you can give them 3 amps, but 150 milliequals of bicarb in along, because if you're giving bicarb, right, you also have to make sure you give them potassium too, potassium chloride. You can give them about 20 milliequals you can give, and in 400 milliliter of sterile water. Okay, really important. Why? Because you want to make sure your bicarb is proper concentration. If you give more fluids, let's say you're giving 150 milliequals in 1 liter, that 150 milliequals is not have like a most concentrated. It's barely going to like fix your pH, right? Right. So that is why your pH it's the quantity of like how much you stir water you're giving. It's really important, right? So in these patients, it's like guidelines recommended that if its pH is less than 6.9, you give 150 milliequals in 400 sterile water, right? So, and also give them, and then what you can do is you can actually repeat their pH after a couple of hours or something, and then see if they're still low. If they're still low, you can still repeat it. Okay. But in our case, our pH is more than 7.1, so we don't have to worry about it, right?
Mm-hmm.
So the most important things we need to focus on is these things right here. Okay. So again, DKA, very simple. Okay, so we'll go in details like which fluids we do, how do we replace potassium and all that stuff, right? So what are the 3 things I want you to take away? Person is coming in, you check their blood sugar levels, they're like 600s, right? And then you got their 600-700 sugar levels, right, on the CMP, and the potassium is high, and then sodium is low, right? Anytime when the patient is coming with hyponatremia, does not matter whether you should not ever blind yourself by thinking, oh, this patient is a DKA, or anytime a hyponatremia patient coming in, you should always rule out hyperglycemia first.
Mm-hmm.
If there is a hyperglycemia, this patient is dilutional hyponatremia, not true hyponatremia, right? So it's really important to basically differentiate between dilutional hyponatremia with the actual like true hyponatremia, because management is totally different, right? Because sometimes the patient's coming in, and if you have a sodium of like 122, 125, right, and you're like, oh my god, my patient is hyponatremic, and then the treatment is fluid restriction in those people, right?
Yeah.
If it's SIADH, for example, right? Yeah. And then if you fluid restrict this guy, DKA, you can literally kill them, right? So what happens is that's why it's so important to like really understand like what are you doing, why we need to check the sugar levels anytime a patient is coming hyponatremia. Especially, you always want to make sure are they hyperglycemic or not, right? Because if it's not true hyponatremia, that you should not fluid restrict them, because the first treatment for hypernatremia in setting of hypercalcemia, and especially in DKA people, is replete what? Fluids, right?
Yeah.
So that's why it's so important to, like, whenever they always tell you to, like, patients with hypernatremia, they always ask you, like, what are their sugar levels, right? You should always reflex yourselves to, like, think about their sugar levels, right?
Absolutely.
Right. So that's what it is. So now let's get in details of, like, so what are the three main things I want you, three or four main things I want you to take away is, number one is,
Replace the fluids.
okay, number two,
Make sure the potassium is okay, and if
Okay.
not, then you replace it.
okay, and then number three,
Then you need to start the insulin.
okay, to correct hyperglycemia, right?
Yeah.
You need to fix the actual problem that started this, the whole thing, right? First, you start the problems that actually occurred due to hyperglycemia. Now, number three is the last thing you want to start focusing. First, you always replace fluids. First, you do not start on insulin without correcting the fluids. Do not start on the insulin without looking at the potassium levels, right? Sugar's not going to kill them, right? In the management, when they come in, if you start them on insulin right away, that will kill them 1st, right? So you always have to make sure you replace one and two first, which is replace fluids, serum potassium. Then is a correction of hypercalcemia, which we will talk about. And then if they initially came in with the pH, that's why you always get what ABG on these people, right? Just to get the pH. If the pH is less than 6.9, we know that some of the enzyme we need that going to help us, remove this, glucose and whatever, once we give them insulin, that's not going to be working efficiently. So that's why we need to correct their pH. Their pH needs to be corrected. We need to give them, if their pH is less than 6.9, we need to give them 150 milli equals of this 3 amps of bicarb in 400
Milliliters of sterile
water
water.
to make sure that our bicarb is enough concentrated to actually have that power to actually bring the pH up, because we're in bicarb, right? So that is the main thing. So anytime DK people, fluids, potassium, correction of hypercalcemia, and pH. That's it. If you understand this much, you already kind of know, like, what are you doing with your patients, right? All right. So now let's get in the detail of starting exactly, like, we'll break it down like fluids and potassium. Okay. So number one, like we said, so this is what, like, up to date says, but like we will. I usually don't like to, like follow like tables, because if you're following tables and not understanding anything, you go to a country like India, where there's no protocols, in the hospitals, right?
Yeah.
You literally don't know what's going on. That's why, like, it's always good to have that thinking with clinical medicine, right? You always want to understand what's going on, instead of like just following the algorithms. And algorithms are easy to follow when you actually know what's going on. So here we go. So then the first thing is giving fluids, right? So if the patient is coming in, let's say, so correction of fluids, right? Correction of fluids, right? That's why. So actually, you know what? Let me just, move this here. Let me just move it here, because the first thing we said is, what are the so what is the management of DKA? So don't get intimidated by all this, up to date, like, these tables and stuff. Just first thing is what? Fluids. What is the second thing we said? Potassium. What is the third thing we said?
Glucose.
Correction of hyperglycemia, right? What is the fourth thing we said?
pH.
pH, pH, initial pH. So actually, kind of the first thing, we should think about, right? So initial pH, right? So let's talk about, so actually, you know what? Let me just, rearrange this thing. Let's put the pH at, like, even 0 level, right? Because that's kind of like the first thing, initial pH, right? If it's less than 6.9. So patient come in, their labs are, we have it here. So we're going to copy this instead of, oh, no, I don't need that table. So now this patient is coming in. Oh, sorry about that. Paste, right? So these are their labs, right? So we already know that we need to correct their correction of fluids. So how do we correct their fluids? So number one, we'll just do, So if they have a signs of shock, right? So the first thing you should always think about these people, DKA people, is like, why they're actually, if they're DKA, they probably did have insulin they were taking, right? So what is the, in, so in addition to management, I also want you to think, what triggered this DKA, this episode of DKA, right? Because if they have like diabetes type 1, type 2, they were probably on insulin, right? So why these people actually went into DKA if they were actually taking insulin, right? So that's the one thing, either it's going to be non-compliance, right? Or sepsis, infection, right? Because these are things you have to make sure, because if you don't know what caused it, like you can fix this problem temporarily, but like these patients will come back again, right?
Yeah, how do you prevent it?
Yeah, so how do you prevent it? So it's really important to understand like what triggered this DK episode, right? So in these people, if there are signs of shock, look for like take a blood cultures, right? UA, right? And all that stuff. So basically rule out infection, right? So if they have septic shock, right, you should give them at least 30 mils per kg of normal saline, right? So if they weigh, like, let's say, if they're weighing like 100 kilograms, so let's say patient is 100 kilogram, then you should give them at least 3-liter bolus fluids, normal saline, right away, right? Just give them bolus 3 liters. Again, these guidelines, like 30 mils per keg, these are just guidelines. Again, it is your clinical, like, judgment when the patient is there. Like, you can do the physical exam, you check their, skin turgor, you can check their tongue if it's dry, mucous membranes, you can check their extremities, it appears pretty dry, you can actually give them more, more than 3 liters, that's fine. But again, like, at least there should at least be a minimum, if there are signs of septic shock, there's a leukocytosis, maybe these patients can have leukocytosis because of vomiting and abdominal pain and stuff. But then if they have, like, blood culture is positive or something, you're thinking highly suspicious infection, they should at least get 30 mils per kg, 3 liters bolus initially, okay? So that's the first thing, right? And what is the second thing? Second thing is if they're hypovolemia without shock, right? If they're hypovolemia without shock, then you should give them at least 15 to 20 cc per kg, which is, or another way, some people call it mils per kg at initial presentation, right? And that is normal saline, right? Like I said, it's really important you pay attention to what? You pay attention to sodium, right? Again, because if this patient is true hyponatremic, would you want to give normal saline right away, this much normal saline? No, you would not, right? Because in these people, when they're true hyponatremic, you should get urine lights on them. You should try to understand, like, before you give them normal saline, true hyponatremic people, you should always, see like why these people are true hyponatremic. So for that people, you always want to do fluid restriction, depending on what the etiology is. When we do hyponatremic lecture, true hyponatremic lectures, we will talk about this. But that's why it's so important. Before you start giving fluids, you always, actually, we should, before giving fluids, we should correct their sodium levels, right? So again, like I said, when we first started, is the normal glucose levels in our plasma is 100. And this guy has how much? 700, which means the sodium at 100 grams of glucose will be around 135 to 145, right? That is sodium given that there's a normal glucose concentration. But this guy has how much extra?
600 extra.
So this guy has 600 extra because total is 700, and normal we know can be 100. So he has about 600 extra, right? So this 600 can be divided by 100, which means he has 6, and then you times that 2, which means his sodium, which is actually 125, is diluted 6 times. So basically, in order to correct this correction sodium is 2 times the extra glucose. You see here. So correct sodium equals to extra glucose divided by 100 times 2, right? So in this guy, what is his extra?
600.
600. Extra is 600 divided by 100 times 2 is equal to what? 12, right? So 12 mil equals need to be added to measured sodium, which will 125 plus 12 is 137. So this actual sodium is 137, not 125, right? So this, when it's corrected, equal to measured plus this one is 12 is equal to 137, right? So that is sodium. So now we know that they are not true hyponatremic, right? So now we just give them fluids and all that stuff. And so what is number 3 is? Number 3 in these people is, so once you initially do this, if the signs of shock, give them 30 mils per keg, you can give them more normal saline. If they're hypovolemic, only dehydrated, without signs of shock, their blood pressure is more than 90 systolic and more than 60 to 70 diastolic. You know that the map is, they're not actually in, they're just a hypovolemic without shock, right? No signs of sepsis or whatnot, right? So that you can always do this. What's number 3? Number 3 is you still need to give more fluids. Still need to give more fluids. So this is you giving them like first 1 to 2 hours, right? You need to give more fluids. So if you give me more fluids, right? So now you need to focus on this corrected sodium. So pay attention to your corrected sodium, correctum serum, sodium. In this cases, so now you need to break down in 3 categories, right? So if it's one category, and then if it's third category and third category. Okay. So first category is if it's a high serum sodium. I should say corrected, high corrected sodium. If it's like, let's say high corrected sodium would be what? More than 145, right? Mm-hmm. Or if it's a normal corrected sodium, okay, which is 135 to 145, right? Corrected. Always pay attention to corrected, not the 125, okay? Mm-hmm. That doesn't really matter to us. So then if they have low sodium, actually low corrected sodium. So if they are actually corrected low sodium is like less than 135, right? And then the type of fluid you're giving them, to keep them on this 250 to 500 mils per hour that you're giving, these were all boluses, right? So now you need to put them on rate here. This number 3 is rate. So these are both bolus. And this one is like maintenance fluids, right? So here, if it's a high corrected sodium, if the high sodium, if the corrected sodium is high, right? If the corrected sodium is high, then or if it's a normal, then you give them what type of fluids? You give them 0.45 normal saline at the rate of 250 to 500 mils per hour. So the question is, why? The reason you're doing it, because if the sodium is high, you're going to give them low, like a hypertonic fluids, right? To bring the sodium low. right? If the sodium is already normal, you should not give them normal saline. You should just give them hypertonic fluid still, and then monitoring their sodium levels and also BMPs, right? But if the corrected sodium is lower, then you can give them normal saline. Again, at the rate of what? 250 to 500 cc an hour. Mils per hour or cc an hour, right? So again, the rate will depend on what? Whether, how much 250, whether you give him 250, whether you give him 350, that is your clinical judgment, right? So if you think your patient is needing more fluids, then you can rate up to 300, 400. If your patient is thinking like, oh, they're actually appears more like, actually feeling, you can look at them, they're feeling better. So you can reduce the rate to 250. If you think like they're still like, having abdominal pain and stuff, they're still dehydrated kind of, you can give them like, more fluids. And like, if they're still having excessive diuresing going on, you can still give them, 300, 400. So it really depends on clinical, but at least bare minimum, they should be getting 250 though. Okay. So that is the first thing, right? So that is your correction of fluids. Okay. So again, every liter you're giving, you have, so you have to pay attention to potassium, right? So number 2 is correction of potassium, right? Repleting potassium, not correction of potassium. Repleting potassium, right? So if your initial, like we said, if the initial potassium is greater than 5.3, why these people are pseudo hyperkalemic, by the way? Because of
the osmotic diuresis.
Pseudo hyperkalemic because of the pH. Remember pH?
Oh, sorry, hyperkalemic. Yeah.
Right. Hyperkalemic, not hypokalemic. Hyperkalemic. Why they are pseudo hyperkalemic? Because of the pH is dropping, and there's a shift from inside the outside the cells, because of the potassium, proton is going to go into the cells, and potassium is going to come out of the cells to the, and then that will come pseudo hyperkalemia. If there's pseudo hyperkalemia, like usually more than 5.3, you don't need to initially replace it. But every single time, if their potassium level is 3.4 to 5.2, every single time, every liter they receive fluids, you should give them additional 20 to 30 milliequals of potassium, right? KCl. Right? So like that's why what I do is normally in my clinical settings, not my clinical settings, but when I'm actually treating a patient with DKA, when I'm giving them normal saline, you can actually give them piggyback on the top of that. So basically, there's a solution here. You can also like throw another, solution on the top of that, so the patient is getting more. But or you can run a separate, line here. You can actually do. So those type of stuff like you can do, but like nurses won't like love you because you actually make them extra do work, because sometimes there's a protocols in place, but like you should definitely know this medicine yourself, because what are you doing? Why are you doing these things, right? You should always ask. Like sometimes there is a pushback, especially when you're resident, intern here, you definitely get a lot of pushback. Oh, you don't know what you're doing, but like you should ask questions to these people, like, why are we doing this? Like we're doing this. This is why we're doing this, because this is how you get better. And that's why it's really important to ask these type of questions, right? Because most of the time, like you'll get pushback, if you're asking a lot of questions, especially to nurses, and also like in ICU, it's really important. But like you should not, afraid to ask questions. It's one of my key take home points here. All right. So if the potassium is less than 3.3, right? What do? Well, you replace 40 milliequals until what? Until potassium is more than 3.4 to 5.2 range, right? That's the main thing, right? So you want to make sure your potassium in that range, right? So the reason, if the potassium is less than 3.3, it's really important, because like replacing potassium is not fun, right? It takes like an hour, because every hour it's like 10 to like 20 milliequals or whatever. So it's really slow, like in terms of replacing it. So that is why. So when we talk about, like, when I sum it up and everything, what I do to actually prevent that from happening. So I'll talk about that in a minute. But that's the most important thing, right? So what is the correction of fluids? What did we do? we actually corrected their sodium levels for hyperglycemia. Which formula we used? We used correction of sodium is equal to extra glucose, which is 600 in our case, and then divided by 100, right? So 600 in our case divided by 100 times 2, which is 12 milliequals, and their measured sodium was 125. So which means this person actually had corrected sodium, is measured sodium plus a corrected one is 137. So they actually are dilutional hyponatremic, but not true hyponatremic, right? So in these people, so then you corrected that. If they initially they have signs of shock, do all this, make sure you elucidate the etiology of this DKA, whether it's a normal medication compliance or whatnot. Take blood cultures, rule out like UA and all of that stuff, rule out infection, right? And then if there is a signs of shock, the blood pressure is really low, the MAP is less than 65, the systolic blood pressure is less than less than 90, and diastolic is less than 70, and then they're really techy, which means they have a signs of shock, right, going on. So make sure you give them 30 mils per kg right away and give them bolus, right? But if they don't have this condition, if they have a hypovolemic without shock, right, then you can give them 15 to 20 cc per kg, and initial presentation, again, that is bolus, and you use normal saline. Usually people use LR or normal saline, but there's no clinical difference. If the other conditions they have on the top of that, some people may have pancreatitis, then it's things will change a little bit. But that's the most important thing. So initial bolus, right, 30 mils or 20 to 15 to 20, whatever, depending on whether they have a shock or just a dehydration, right? So once you give initially those fluids, then you have to give them, still need to give more fluids, right? Then you pay attention to your corrected sodiums, right? If the corrected sodium is higher, you should not give them more sodium. Makes sense, right? So, and if it's normal, then you don't need to give high dose. So what you do is, you don't need to give normal saline. So you can actually, if it's a high corrected sodium and normal corrected sodium is normal, then you give them a half normal saline at 250 to 500 cc an hour, right? And the reason is now your body needs, again, remember when you go from high sodium to low sodium, high to low, your pons will blow. And then low sodium to high sodium, so low to high, your pons will die. So that's why you kind of fix, because these people actually are at high risk, also at risk of these conditions as well. That's why the choice of fluids that you're doing, whether you're doing normal saline or half normal saline, it's really important, and that really depends on your corrected sodium levels, right? So if it's a high, corrected sodium is high or normal, then start them on 0.5 normal saline, that's fine. And then if it's a low, then yes, you can give them a little bit more normal saline, which is 0.99 grams in 1 liter of water or whatnot, right? So you're giving that, and then making sure every single time if they've received bolus fluids, 1 liter, make sure you actually giving them fluids. If you are giving them every let's say this guy is running at 500 cc an hour, so in 2 hours they will receive 1 liter of fluids, right? So make sure they actually receive this, right? Because you're diluting their potassium as well, right? So you want to make sure you're replacing that potassium as well at the same time, right? But in our case, this guy is at 5.6, right? It's more than 5.3, which means this guy is a pseudo hyperkalemic, so we don't need to initially replace it. We can actually give this water to actually dilute it, and eventually, that's why we're repeating this BMP every 2 or 3 hours, right? Or 4 hours, whatever, right? The third most important thing is hyperglycemia, right? Hyperglycemia, right? So I will take this whole thing right here and we'll make it smaller, okay? Resize this, okay? Right, so that's number 1, that's number 2. Now we focus on hyperglycemia, right? So what do you do in hyperglycemia? So, well, the thing is, these people have, so what you do in hyperglycemia, you need to, because in normal people, you have to understand normal, right? Normal, we have basal insulin, right? Right, basal insulin. Basal insulin is it's basically it's a balance of glucagon to insulin, right? In these people, they have no basal insulin. That's normal, right? But in DKA people, so in DKA, there's no basal insulin, right? Especially in type 1 diabetes, there's no basal insulin. So if there's no basal insulin, you need to give them basal insulin. So how are you going to give this basal insulin? Well, you have to give insulin drip, right? So basal insulin, you have to give insulin GTT, right? Which is you have to give them insulin drip. But insulin drip, basal insulin is not going to fix that high amount of glucose levels, right? So what do you need to give initially? And before you start this, this insulin drip, this is second step. Before you start this, you actually have to give them, bolus insulin, right? Again, the whole everything goes back to normal physiology, right? Remember, when you eat something, in normal people, you have spike of glucose goes up, right? So what happens to your insulin level at that time? So your insulin level are basal, right? Like low level. And when you actually have high glucose, then your insulin level also spikes up, right? Insulin level spikes up and it goes down again, right? Same thing. So if now you have this person actually have similar condition right here, DKA person, right, which has a 600 milligrams of glucose or 700, right, present in the blood. Now you need to give them the spike of the insulin, right, and then you need to give them this level, right. So you need to give them this spike, you need to give, and then you need to supply them basal insulin. So this is your basal insulin right here, and this is your bolus insulin. Right. So what is a bolus insulin that you have to give? You have to give them at the 0.1 unit, 0.1 unit per kilogram IV bolus, right? So let's say this person is 100 grams, 100, not 100 grams. That would not be a person actually. So. Let's say it's a 100 kilogram, right? This person is. So how many units you're giving? So then the calculation is what? The calculation is going to be 100 grams times 0.1 units is equal to 10 units, right? So they should receive IV. So to simulate this peak, right? They should receive IV of 10 units, right? IV. So bolus. So that is why we're giving them bolus. Our body normally also has the same thing, bolus in our body, right? So our body actually, when we eat, we spike up the glucose and we have a bolus insulin coming from our pancreas. And then our body is maintaining the plasma, like basal insulin, right? So same thing. Now we have to give them basal because their bodies actually have so much high glucose. It seems like, they just ate something, but, their body doesn't have insulin, right? So you're giving them a bolus insulin, 10 units. And after that, you start them on basal insulin, which is their insulin drip, right? Insulin drip, this one is going to be on 0.1 units per kilogram per hour, right? So you start them on that. So sometimes, in some conditions, if people have some other conditions going on, if they're severe hyperglycemia, you can give them this rate can actually increase a little bit more. But guidelines recommended right now is like it's a 0.1 unit per kilogram per hour. So now you're starting them on small base. So basically, this is actually giving them basal insulin, right? So that's pretty much it. So then you give it this, and that should be, and then so all these three things you're doing, right? So you're doing number one, you're doing number two. That's the most important things. Make sure you replace this, right? And then you're fixing the hyperglycemia, right? And then while you're doing this, you have to make sure, what is insulin going to do? So here, you have to make sure you understand what is insulin going to do. Number one, it's going to fix your peak glucose levels, right? Which is by bolus. Peak hyperglycemia, that is what? Bolus, right? You fix that. What else does it do? You're giving them basal insulin, that is your drip, right? What is number three? What does insulin do? Insulin actually do what? Insulin stimulates, it also, put all this, glucose, start putting all this GLUT4 transporters here, right? And then now they're going back into your, glucose is removing. And also like glucokinases, now your body is like start making fatty acid synthesis, cholesterol synthesis, and all that stuff we talked about. It also stimulates, in addition to that, it also stimulates your sodium potassium pumps. Okay, so if you stimulate the sodium potassium pumps, what do you do? So again, pump the K in, right? Pumpkin, right? We have the mnemonic. So what happens now? Your potassium will start going back into the cells. Right? That is why it is so important when we looked at the potassium, right? If it's less than 3.3, you should not start what? Insulin, right? It's so important because what happens is if you start putting back this potassium into the cells, if they're less than 3.3, you can actually cause rhabdo, right? Because hypokalemia causes what? Rhabdomyolysis, right? And also, it can cause arrhythmias. Remember the U waves in hypokalemia? It can cause arrhythmias, right?
Fatal arrhythmia.
Yeah, so it actually can kill these people, right? So that is why it's so important. And that's why, like, when you actually have these three things running simultaneously, what is so important?
Q4 BMP check.
Exactly. So while these things are running simultaneously, we want to make sure everything is running smooth, right? It's kind of like a game. It's like a video game you're playing, you know. No, seriously.
Yeah.
So then, number 4 is to monitor monitor the sodium, monitor the sugars, monitor the potassium, and other stuff, right? What you do, it depends on like 2 to 4 QH, Q2 to 4H BMPs, right? Every 2 to 4 hours, you're running the BMPs, right? And then the most important thing when actually, so like, assuming these things are working just fine, right? Assuming these things are working fine, what is your let me see here, right? So assuming these things are working fine, what are you going to do? Well, you want to make sure. So now let's say their labs come back, right? You want to what are you monitoring on the BMP is the question is, right? You're monitoring the potassium, you're monitoring the sodium, you're monitoring what else? You're monitoring most important bicarb, right? Bicarb. What else are you monitoring?
Anion gap.
Anion gap, which is a bicarb, and yes, so you can actually do that. Chloride. You can do anion gap. The most important thing is also glucose too, right? Yeah. So these 4 things you're monitoring. Yes, anion gap definitely, because otherwise you wouldn't know like whether you're heading in the right direction or not heading in the right direction, right? So let's say initial their labs were sodium, so now their sugars is like, let's say, I don't know, approaching like 200, right? Their anion gap is, let's say, I don't know, it's like still like 15, right? And the sugars are corrected, but the anion gap is still like, I mean, not anion gap, the bicarb is 15, and then sodium is, let's say, 135, and then chloride is like, let's say, like 105 or something, because you give chloride, that might be higher, and the potassium is, let's say, 4.5 or something, and BUN is 20, and then creatinine is like improving because you're giving them a lot of fluid. So before it was 120, and let's say now it's improved to like 1.10 or something, right? So what is your A gap now here? So A gap is anion gap, right? Is it so 135 minus 105? We don't really care for potassium. 105 plus 15, right? So the anion gap is almost what? That is
15.
So 120, so it's 15, right? So which means it's kind of elevated, right? It is like still like getting there, but like mildly. So here, what was the anion gap? We don't know. This anion gap was like probably, let's say this was like 95 or something. The anion gap was what 125, right? Sodium 125 minus what was this is 95 plus 14 was the gap here. That is like almost 99 plus 109 minus 125. So you're looking at what's
16.
Probably. So yeah, so 125 minus 95 is so like we can just make this even number right here. Like let's say it's a 15. So like that's 95 plus 15. That's 110 minus 15. So like yeah, it's about 16, right? So it really didn't improve, right? So what happens is, which means your anion gap is here, your anion gap is still elevated, right? Normal NA-GAP is up to 12 if you're not accounting for potassium. Is up to like, so still elevated, and your sugars are going down, right? So now at this time, like which means like your DKA hasn't resolved. DKA has not resolved, right? So DKA has not resolved. So what are you going to do? If your anion gap is not resolved, I mean your anion gap is still elevated, DKA is basically telling your DKA is not resolved yet. But your sugars are going down, right? So what do you need to do in these patients? In these patients, you need to decrease, you actually remember, like, which fluids were they on, depending on, let's say, assuming whether they were on, whether the patient was on, whether the patient was on normal saline or half normal saline fluids, right? If the DKA or A gap is elevated, you should do what? Because what are these people are on? They are on what?
Insulin.
Insulin drip, right? Because we give them basal insulin, and what is driving their sugars down?
The insulin that we're given.
Insulin bolus, but more importantly now, what is dropping their insulin more so is insulin drip. So which means now they don't have any source of glucose coming in because the insulin is always there, right? So their sugar levels are dropping. So what are you doing now is, like, either you have to decrease the insulin drip to maintain those glucose levels, but if you stop the insulin drip, you will push them back into DKA again, right? So what do you need to do? So we cannot stop. So we can't stop insulin drip. So whether the patient was on normal saline or half normal saline, if the DKA gap is elevated, has not resolved, and patient glucose is approaching 200, 200s, which is driven by insulin drip, right? So two things we can do now, right? To basically stop the glucose dropping further, right? Either we can stop the insulin drip, or find a source of glucose, right? Because we cannot let the glucose drop below 200 if the DKA has not resolved. So two things we can do. Either we can stop the insulin, or either we can find a source of glucose. So what is the right thing to do? Can we stop the insulin drip? No, we cannot. If we stop the insulin drip, let's say hypothetically we stop the insulin drip, you basically push them back into hyperglycemia again, right? Because that insulin drip is basal insulin, right? So if they stop the basal insulin, they will go back into hyperglycemia, they will go back into DKA. Because what happens now? Their body will go back into fasting if there's no insulin. So we'll say if stop insulin GTT, then body goes into fasting again, and then what happens is they will go hyperglycemic again, they will go into DKA again, right? So we should not do this, right? That is the whole point. We should not stop the insulin drip, right? And so what do we do? Well, especially if their DKA has not resolved, right? So what do we do? The DKA, the gap is still elevated, DKA is still there, right? Because the bicarb is still elevated, right? So what do? We just basically switch their fluids, we find them a source of glucose, right? We switch their fluid from normal saline to what? D5, which is sugars, plus half normal saline. You understand?
Yeah.
And we just basically find them a source of glucose by giving the D5, and then this rate can be adjusted depend on what? Depend on how much sugars are dropping. Dropping, right? So let's say the DK has not resolved, this patient has a sugar of like 150, you can increase the rate to 300. Basically load them with glucose again, right?
Just blast them.
Exactly. So if the sugar levels are like 200, then you can increase the rate to like keep it at 100 or 200 or 150, right?
Yeah.
If the patient is like becoming like 100 and DK has not resolved, so you have to give them more glucose, right? So that's the most important thing, and that's why we're doing these things. So that's what you do, okay? And then eventually what happens is at number 5, so let me see here. Sorry, it's going to take a long time. Copy. Okay, so that's the most important thing, you know, like we're going to paste here and this, right? So this is like literally a nutshell. So now, so this is what you're doing here, right? So you're fixing the hyperglycemia. So now, like, you know, again, you repeat the next BMP, right? Now their BMP is coming back, and now let's say your chloride is like 105, let's say it doesn't change. Your sodium is like, let's say 130, I don't know, let's say it's 140 now or whatever. I mean, let's say it's like it stays about the same, 135, and your potassium is still, you know, 4.0 or something, and your bicarb has, you know, improved to, let's say, I don't know, like 20 or something, like, no, let's say 22 or something like that, right? And then BUN, since you're giving a lot of fluids, your creatinine is improving to 0.99, and the sugars are like, you know, around 180-ish, right? So now what happens is you calculate the gap. What is the gap here, right? So gap is 135 minus 105, that's about 25, right? No, actually 30, and 30 minus 22 is what? About 8, right? So now the gap is normal, right? Did I do the math right?
Yeah, 127.
No, 135 minus 105, that's 30. 30 minus 22 is 8, right? So 8 is normal, right? And then if this is normal, now can switch, or should not say switch, transition insulin GTT to subcutaneous, but have to make sure you overlap. Okay. So this is where we're at, right? So we started from the fluids, we corrected the fluids, we replaced the potassium, and then we're fixing the bolus, you know, peaking this peak 600 glucose, right? We're giving the bolus, and then we're giving them, you know, basal rate, and then we're monitoring their, you know, BMP. Their A gap is, let's say, hasn't closed, but the sugars are dropping below 200. What did we do? Can we stop the insulin drip? No, we should not, because they will go back into DKA. What did we do? We find them a source of glucose. Meanwhile, we were waiting for the DK to resolve, right? And then basically switch them to D5, right? The glucose plus half normal saline rate, depending on how much you want to maintain your 200 glucose, right? And then eventually, at some point, you know, the BMP improves, the A gap close. Now you can transition from insulin, basal insulin, to back to their subcutaneous, because like putting an IV in somebody forever is not a feasible thing, right? So we have to make sure, you know, they're getting a subcutaneous insulin and Lantus and all that, you know, the stuff, right? So now what we do, now we give them basal insulin in the form of So now we give basal insulin that we were initially giving with the GTT, right? Now we're going to give them in the form of subcutaneous, which is Lantus. That's why Lantus is like, given for basal regimen, right? Because it's long acting, it just stays in the blood like kind of longer, right? And that's why it's like a half-life is like 24 hours or something like that, right?
Yeah.
So that's what it is, right? So now we're transitioning, but when we give this subcutaneous, the absorption may take time, right? May take time. So hence we need to keep patient on insulin drip. Even if the gap resolves, we need to keep them insulin drip for 2 to 4 hours while we gave them subcutaneous insulin, right? So, but the rate of insulin drip before, how much was it? It was 0.1, right? Now it will be 0.01 instead of units per kilogram per hour, rather than 0.1 units per kilogram. Make sense? Now we reduce the rate because we know that our gap is closed, because if we keep this patient on, like, we give them a Lantus, right? We're giving them a Lantus, right? And on the top of that, we're keeping the insulin drip. It can actually cause hypoglycemia now, right? So for that, to prevent the hypoglycemia, because remember, we need to have the 100 grams of glucose levels in the blood for what cells?
For the red blood cells.
Right. So now we have to protect the RBCs again, right? So now we need to make sure they don't become hypoglycemic, right? So what do? We reduce the rate of the insulin drip, right? So once we repeat, and plus we will start them on sliding scale plus Lantus plus sliding scale insulin, right? And then once we repeat the BMP, and then sugars are controlled, right? Usually like 100 to 180s or whatever, and then gap is normal. We can DC the insulin drip altogether, right? That's it. And then what do we do next, right? So, well, the patient gets ICU downgrade, and then all that fun stuff, right? We have to call the insurance and all that stuff, right? And call the physician. Hey, can you accept my patients? And all that stuff, right? Yeah. So if the insurance is now, you have to call, like, oh, should we do it to IM team, or should we do it to private hospitalist, and all of that stuff. So this is in the nutshell, right? So this is where, you have any questions?
Yeah, one thing that I wanted to mention was the fact of eating. I usually like to make sure a patient is able to tolerate a whole meal
before you start.
Keeps it down
Before
I give them the actual bowl.
Lentus?
Yeah, the Lentus.
So, the idea is, what the idea is behind that? So that's a great question, actually. That is something, a lot of people, so before transition, right? So now your question is around transitioning from insulin drip to subcutaneous, right? But their overlap is at least 2 to 4 hours, right? For GTT insulin, but at lower rate, right? So that's a great question, right? Because if the patient cannot eat, right? Let's say that so right here, if the patient is still having vomiting, right? Patient is having vomiting, nausea, right? So they're not able to tolerate. So if you're not able to tolerate, what happens? And then let's say here, let's just assume that you already, patient is currently back on, why do we do overlap this? Let's just talk about this first. Why do we do this overlap? What is the whole point of doing this overlap?
The time for the sub-Q to kick in?
Yeah. So what is the whole point of doing this in the first place? Because it's really, because a lot of people, like, I've asked, the people that I've worked with, like, yeah, we do overlap, but like, why do we do overlap, right? That is the question you should, every person as a resident should ask, like, themselves, like, why do we do overlap, right? The whole point of doing overlap is to prevent what? So basically, there will be transition during transition period. There may be a window which during which insulin levels are not adequate. So you stop the insulin drip, right? And then you switch them to subcutaneous without doing this overlap, let's say, right? What happens there, it may be a window that insulin drops from the blood very low. What happens again?
So you go right back up.
So you go, I mean, if you have no insulin now, so what happens? There's a balance of glucagon to insulin, right? So your body, now your glucagon is going to be higher than insulin. Your body goes back into fasting state.
Oh, wow.
You go back into DKA. This is what we call what? Rebound hyperglycemia. So basically, we're doing this transition overlap to prevent what? Rebound what?
Hyperglycemia.
Hyperglycemia. Right? Because what happens? If they have a rebound hyperglycemia, what do we need to do? We need to start them back on insulin drip.
Right back to ICU.
Right back to ICU, right? So that is the whole point, right? So like we need to understand why this overlap is so important, right? Because we're preventing them. There will be a period, if you don't transition them properly, there might be a window where the insulin levels are not going to be adequate and you go back into DKA.
The body thinks it's starving and it does everything.
Hyperglycemia again.
Yeah.
You have no insulin. You're not putting back into the cells. The cells are sending a signal. Hey, there's no there's no glucose coming into me. Even though you have high amount of glucose, your liver start doing a lot of gluconeogenesis, right? Yeah. And then you flood your blood vessels again, plasma again with the glucose. Now you cannot remove it. Now you go back to square one, back to DKA. So that's why you do this overlap. So important, right? So that's the same thing, right? So if the patient is having vomiting and nausea, right? So they're not eating, right? Their fasting levels, they go back to fasting, right? So what happens? Well, you're giving them, so now they're fasting. So you stop the fluids, you stop the D5, right? Because you already stopped them fluids, right? You stop the D5, and also what else you do when the gap resolves? We also stop the insulin drip, right? We also stopped that because the gap closed, right? And then what else do we do? And then, they're not eating, right? Not eating. And what else did we do? We give them
Sub-Q.
Lentus, subcutaneous. So now you're giving them more insulin, but then they have no source of glucose. In these people, the glucose source is eating. If they're vomiting and nausea, they're not eating, right?
Yeah.
So you're literally giving them insulin again. So what do you do when the patient is? So you keep them on insulin drip and also D5 too, depending on the sugar levels, right? If the sugar levels are low, then you don't need to start D5, but then you want to make sure you actually keep them on insulin drip until they are able to eat. It's really important, and then do not give them Lentus until they are able to eat. It's really, really important because it will really screw up the, these things. But understand this point of rebound hyperglycemia is really important. There are some studies that actually people are mentioned. I think there was a couple of studies, we can talk about later. One was done at the University of Colorado. There was sample size was 61 patients. What they did was they did not wait for transitioning until the DKA resolved. like how we keep the patients on like insulin drip. Once their DKA resolved, then we transition them to Lentis. But in this study, they actually did not wait until DKA resolves. They actually
Oh.
gave them high dose, like a weight based insulin Lentis in within 12 hours of starting the insulin drip.
Oh.
So what happens in these people, they actually had less episodes of rebound hyperglycemia. So there was like less failure of insulin to subcutaneous transitioning, and in these people, and that's actually I learned from Dr. Huck. So yeah, anyhow, so that's pretty much it for us, right? So again, so DKA management, management. If you want to go with the up to date, giving them fluids. We already talked about what fluids, right? We talked about what are you going to do with the fluids, right? So fluids correction, and depending on if they have a shock or just a hypovolemia without shock, right? So give them bolus here, right? What else you do? And after that, you start them on maintenance fluids. From maintenance fluids, make sure you check there, corrected sodium, right? Because you want to maintenance fluids, you want to make sure what type of fluids you want to check. If the sodium is high or sodium is normal, corrected, right? If it's normal, you start them on D5. Sorry, not D5. That will really screw up things. Have normal saline at 252, 500 cc an hour, right? And then if it's sodium is low, corrected sodium is low, what do? Start them on normal saline, right? Because if it's low, then you give them normal saline, right? And normal saline, which is 0.9, and that's it, right? 252 cc an hour. And then also you're giving this fluids, whether it's a normal saline or let me see right here, whether it's a normal saline or half normal saline, until the glucose levels are 200. Okay, once it's below 200, switch the fluids to, given that no DKA has not resolved, what do? You start them on D5 plus half normal saline. Okay, that's it. And then what is the second thing? So that's the first thing always, right? What is the second thing? Potassium, right? Always potassium repletion. If the potassium is greater than 5.3, then you can start them insulin. Number 3, right? Start them insulin. But if the potassium is 3.4 to 5.2 or 5.3, whatever, then you can start the insulin. You can start the insulin like bolus and basal, right? And basal is what? Insulin drip, right? GTT. And then you can do this, you can do this, you can do this, right? But making sure every liter, but in this settings, you want to make sure this is every 1 liter of fluids, they're receiving what?
20 to 30.
20 to 30 milliequals, 40 milliequals. You can always monitor it, right? And then number 3, if it's less than 3.3 potassium, initial, right? Initial. If it's less than 3.3, do not start. Do not start insulin, right? So do not start it until. So basically here you should replace potassium until it's above 3.4 or something. Okay, that's it. And then you start on basal bolus insulin. Then they keep on running on basal insulin drip, right? We already discussed the 0.0, 0.1 units per kilogram per hour, right? And then we just keep on, going on that, and then, monitor their, Q2 to Q4H, for HBMP levels, right? And if the gap closes, If the gap hasn't closed, the sugars are approaching 200, switch the fluids, right? All these things are running simultaneously, right? And then what you do is from the basal, and once the gap close, then you transition, right? Transition to subcutaneous while overlapping insulin drip at lower rate, right? At lower rate. What lower rate? 0.001 or 0.02, whatever you feel like, depending on the sugar levels and all that stuff, right? And that's it. To do what? To prevent what?
Rebound hyperglycemia.
Rebound hyperglycemia. That's really important, right? That's the whole point, right? So you really need to understand like why you're doing the things you're doing, not just yes, please transition the drip. We just overlap for 2-3 hours, but why? Right? That's the most important questions, and that's what makes medicine more fun. Anyhow, so that's pretty much it, right? So then you once yours does this, right, subcutaneous lentis, and then it's already then you can DC the insulin drip. Make sure like when you transition, the most important that actually prevents a rebound hyperglycemia is patients are able to eat, tolerate, pure diet, right? And then that's it. And then because you already given them subcutaneous, they can actually become hypoglycemic now, right? Because if you stop the, you give them lentis, or they can become hyperglycemic. Sorry, because what you do is they're not going to be able to eat, and then you just basically give them a.
You're gonna tank them.
Yeah. So anyhow, so discontinue insulin GTT at this point, right? And then after that, BMP is okay. Then ICU downgrade, right? I mean, there's just so many protocols in the hospitals to do these, but I would just always like to know what I'm doing with my patients rather than just the patient is on protocol, and okay, can you just tell me, ask the nurse, hey, can you tell me when the gap closes? I'll just come and downgrade the patients. I'm not there for scut work too. I mean, definitely as a resident you do scut work, but definitely you should learn medicine as well, right? Yeah. But one thing is, if the patient initially came pH is less than 6.9, give them 2 to 3 amps of bicarb, right? Plus KCl. And that's it. So that's your total management of DKA. Okay. Any questions?
No.
All right.